In this lecture, I want to discuss some of the myths and misconceptions about evidence-based veterinary medicine. There are a number of objections to evidence-based veterinary medicine, and some of them are completely legitimate, but unfortunately some of them are based on a misunderstanding of the principles or the details of evidence-based veterinary medicine. And I think only with a clear understanding of what it actually is can we have productive discussions about how best to construct and employ it. Of course, the classic definition of evidence-based medicine in general, which applies in the veterinary field as well, is Sackett's definition, that it is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The key here is that evidence-based medicine is a process. It requires a conscientious effort, and it is an explicit process. It requires us to be clear with ourselves and with our clients and with our colleagues about the nature of the evidence we're using to justify our decisions. It's also a set of principles and methods focused on improving clinical decision-making and ultimately the care of individual patients. It means integrating what we know as clinicians from our own experiences with the best external clinical research evidence. And systematic research has a number of advantages over other forms of evidence, and evidence-based medicine does give preference to controlled systematic research because it does a good job of compensating for some of the errors that can be found in other sources of evidence. Evidence-based veterinary medicine is a process. It begins with the clinician asking a specific answerable question about the medical condition of a particular patient, and then conducting a search to find the relevant research evidence that pertains to that question. That evidence then has to be evaluated, and there is a schema for evaluating evidence, research evidence in evidence-based medicine, looking at the quality, the level, the limitations, and all of that then leads us to some conclusion, to making a decision, which is ultimately the point of engaging in this process. We then assign a level of confidence to that conclusion, and that's where the explicit processes of evidence-based veterinary medicine are so helpful, because once we've made a decision, it is useful to us and to our clients to have a clear and open understanding of the limitations of the evidence that underlie that decision. There are many possible objections to evidence-based veterinary medicine. There are philosophical objections. Proponents of a postmodern view, for example, would say that evidence-based medicine privileges certain ways of looking at the world, certain cultural or philosophical paradigms over others, and that that's not legitimate. There are methodological objections, the reliance on randomized clinical trials or the particulars of how statistics are used to support evidence and decision-making. There are aesthetic objections. Some people feel that evidence-based medicine diminishes the value of the human element in medical decision-making. And there are pragmatic objections. Often there is not enough evidence or not adequate quality evidence to help us practice evidence-based medicine in a practical and useful way. Some of these objections are more legitimate than others. The important thing is that we understand what evidence-based veterinary medicine really is, so that our debates and discussions about it are predicated on an accurate understanding and not on myths or misconceptions. One of the most prevalent myths about evidence-based medicine is that it is pointless to even attempt to practice it in the veterinary domain because there simply is no evidence. And like many of the myths and misconceptions I'll discuss, there is an element or core of truth to this objection. However, it is often overinterpreted or expanded beyond the point that is legitimate. So, for example, in looking at the question of whether oral glucosamine might be helpful in treating osteoarthritis, in human medicine, this data has been reviewed. Most recently, in 2009, the Cochrane Review provided a systematic review looking at this question. And this included 25 studies with close to 5,000 patients. Some of these studies lasted up to 2 years, and that was a pretty solid evidence base from which to make a general conclusion, an answer to this question. And for what it's worth, the answer seemed to be that there was very little evidence of a real benefit for glucosamine. In attempting to look at this question in the veterinary domain, I looked at the evidence in 2010 in dogs and found all of 2 randomized controlled trials lasting only 2 months and involving less than 115 dogs. So clearly, we do have a problem with evidence. There is a lack of adequate quantity and quality of controlled clinical trials, in particular in veterinary medicine, and that does hamper our ability to practice evidence-based medicine in the way that we would ideally envision it, particularly as translated from human medicine. However, it's important to recognize that this is a solvable problem and that, in fact, already there's been great progress in this area. This is a graph produced by the Center for Evidence-Based Veterinary Medicine showing the total number of veterinary systematic reviews. And clearly there has been a dramatic increase in just the last 10 years in the number of systematic reviews in veterinary medicine. And this is a high level of evidence that is very useful to clinicians. So the improvement in this kind of review makes evidence-based medicine much easier and more realistic for clinicians to practice. It's important to understand that evidence-based medicine is about generating evidence as well as about supporting clinical decision-making and using evidence to help make decisions in general practice. So evidence-based medicine is useful precisely because of the deficiencies in the evidence base. It allows us to most efficiently and effectively generate the most useful evidence possible. Evidence-based medicine is also about evaluating the existing evidence in ways that allow us to establish a level of confidence in our conclusions and our recommendations. And so certainly the deficiencies in the quantity and the quality of evidence are part of that evaluation. Evidence-based medicine allows us to look at those variables and incorporate them in our decision-making by helping us to explicitly and formally evaluate the limitations in the existing evidence base. Evidence-based medicine is also very important for informed consent. Animal owners are entitled to have all the information they need to make decisions about the recommendations and interventions that veterinarians recommend. And part of this information is an awareness of the deficiencies and the limitations in the existing evidence base. So even in the absence of large quantities of high-quality evidence, evidence-based medicine helps us, again, to formally and explicitly discuss with our clients the limitations in the evidence base, the impact that has on the confidence that we have in our conclusions, and this allows them to make better informed decisions about the interventions to employ for their animals. It's important to note also that evidence-based medicine is about information management. It's not simply producing information or using information to make decisions, but about helping us to efficiently manage the volume of information that we have. And even in the current situation where we would certainly like better and more clinical research evidence in particular, there's a tremendous amount of information, published scientific research as well as basic science information, that veterinarians have to manage in order to efficiently make decisions in the practice. The traditional management of information has been under what's sometimes called the just-in-case knowledge model. This implies that veterinarians take in as much information as they can, that we stuff into our brains all of the basic science and all of the clinical research evidence and all of the information currently available about the diseases that we're dealing with, about health prevention interventions, and about healthcare interventions, and that we have all this information ready and waiting in our heads just in case we need it for a particular client or patient. Clearly, this is a very inefficient information management model with a lot of opportunity for error and a high cognitive burden on the veterinarian. Evidence-based medicine supports a model that is more commonly known as the just-in-time knowledge model. This means that we have the ability or the skills, the training, the tools, the techniques to identify our information needs in each particular case, and then to go and identify the information relevant to meeting those needs, to answering our specific clinical questions at the time that we need it. This places the emphasis on identifying what information is needed, finding that information, appraising it, and then using it efficiently in real time, rather than simply carrying around large quantities of information of questionable or unknown reliability, ready and waiting just in case we should need it. So evidence-based medicine can be very useful to us even in the current information environment in which we have less high-quality evidence than we'd like, because it allows us to manage the evidence that we do have more effectively and efficiently. Another myth or misconception about evidence-based medicine is that it is concerned only with randomized clinical trials. And this leads to a number of objections to using evidence-based veterinary medical approaches. For one thing, there aren't randomized clinical trials for many interventions. And so the understanding is that without these, because evidence-based medicine is obsessed with randomized clinical trials, if we don't have any, we simply can't do anything. Evidence-based medicine does not allow us to make decisions in the absence of randomized clinical trial level evidence. Another objection related to this is that even when we have evidence like that, we can't really make decisions about individual patients based on population data. The randomized clinical trial produces information about what happens in groups of patients, but every individual is different, and so that evidence is not particularly useful to the clinician in managing individual cases. And finally, the argument is made that the obsession, if you will, with randomized clinical trials in evidence-based veterinary medicine leads other kinds of evidence to be unfairly ignored or dismissed. Now, there are a number of problems with this misconception. The first is that while randomized control trials are absolutely quite high in the evidence hierarchy in evidence-based medicine, because they are understood to most effectively control for many of the sources of error in other kinds of evidence and other ways of supporting our decisions, randomized control trials are still only one of many kinds of evidence that are incorporated into the evidence hierarchy in evidence-based veterinary medicine. So it's understood that many other kinds of evidence exist and that they have a useful role to play in informing our clinical decision making. And David Sackett, who is often viewed as one of the founders of evidence-based medicine in the human domain, and whose definition of evidence-based medicine is still the most commonly used, was very explicit in the same article in which he helped to define evidence-based medicine about the role of randomized clinical trials. And he said quite clearly that evidence-based medicine is not restricted to randomized controlled trials. While these are the gold standard, because they are the best form of evidence in terms of compensating for the kinds of errors that have traditionally led us to the wrong conclusions in medicine, nevertheless, some questions don't require randomized controlled trial evidence, or some clinical needs are urgent enough that it's simply not possible to wait for that level or quality of evidence to be available, and decisions have to be made. And often there are no randomized trials addressing specific questions, and so the next best level of evidence or kind of evidence needs to be employed. It was recognized from the very beginning of evidence-based medicine that randomized controlled trials, while having a special place, are not the only kind of evidence. So it is a bit of a myth to say that this is an obsession of evidence-based medicine. The idea that population data don't help us in making decisions about the care of an individual patient is something known as the aggregate fallacy. And it incorporates, in my mind, a couple of particular kinds of errors. And so I've given them my own names. The first I call the Vegas delusion. This is the notion that because population data ultimately is statistical in nature and probabilistic, that it doesn't tell us what's going to happen in any individual case. And there's a certain truth to this. The analogy that I'm using here is games of chance or gambling. It's clear that the odds, the statistics that can be applied to these kinds of games, only apply to populations, to multiple trials. And so while it is true that it is very unlikely for any individual roll of the ball in roulette, for example, is likely to be a winner, nevertheless, it's impossible to predict precisely how any individual round of any of these games of chance will go. All we know is overall, on average, what's likely to happen. And while this is true, it leads to the misconception that it is therefore a good idea to ignore the statistics or the odds and simply play these games from the perspective that, hey, some individual has to win, why couldn't it be me, right? The odds don't tell me what'll happen in my particular case, so I might as well go ahead and play. And this works out very well for the owners of casinos who make a tremendous amount of money on this misconception or misunderstanding of statistics. It doesn't work out so well for the individuals who play these games and who more often than not lose. The fact is that while the statistics do not tell us precisely what will happen in any individual case, in medicine or in gambling, nevertheless, the best decisions, the most likely to be successful, are those decisions that are based on an understanding of what the odds are and on using those odds to help guide our decision making. So it's just as true in medicine as it is in gambling that paying attention to the statistical data still provides a better and more effective decision making than ignoring that data. The second myth associated with this notion that population data can't help us in the management of specific patients is what I call the snowflake fallacy. We all know that every snowflake is unique and different, and we all know that all individual patients are unique and different. Their circumstances, their biology are unique. However, this does not necessarily imply that the uniquenesses or differences between patients are always relevant when making clinical decisions. It may be true that two individual people have different color hair, for example. That's a uniqueness or a difference between them, but it's not necessarily relevant to the effect of a particular chemotherapy drug on a particular kind of cancer they may have. Not all differences matter. And population data can be very useful in helping to manage the care of an individual patient because many of the characteristics that do matter and that are relevant are the same between different individuals. So while it is true that population statistics don't necessarily provide perfect predictive value for every individual case, the Vegas delusion reminds us that making decisions on the basis of population data is still a better bet than making decisions on the basis that individual outcomes are unpredictable and anything can happen. Similarly, while it is true that all individuals are different in various ways, it is not necessarily true that these differences are always relevant, and population data can provide us with very useful information that applies broadly to many individuals in terms of managing their healthcare. Finally, the notion that evidence-based medicine focuses or overemphasizes the randomized controlled trial suggests that the experience of individual clinicians is not valued. There are a couple of things I can tell you about clinical experience from an evidence-based perspective. The first is it's pretty poor quality evidence. The reality is that our individual perceptions are unreliable. They are subject to many kinds of error, and the whole reason that science exists and has been so stunningly successful in helping us understand the natural world is that it compensates for many of those errors. So there's no question that the individual experience of the clinician is often very poor quality evidence. That said, the experience of individual clinicians is also completely indispensable to medicine and will never be replaced by evidence-based medicine methods. Individual clinical experience is required for many things. It is required for identifying the information needs and the specific questions that need to be answered in the case of a particular patient. It is necessary for deciding whether any evidence that is located is relevant or for evaluating the quality and the limitations of that evidence. The clinician is absolutely vital in deciding how evidence should be applied in the case of a particular patient. And of course, as is so often the case in veterinary medicine, individual clinicians must make decisions in the absence of high-quality objective research evidence, and this requires clinical experience to inform those decisions. Evidence-based medicine does not in any way suggest that clinical experience is useless or not important. It merely points out that it has significant limitations and that there are often situations in which controlled scientific research evidence can better guide our decision-making. I'm going to introduce you to what I consider three of the most dangerous words in clinical medicine, in my experience. Again, this does not suggest that individual clinician experience is not important or valuable or useful or often correct, but it does help us to remember that individual experiences are subject to quite a few sources of error and are often less reliable than they feel to the clinician. An example of this, which I think is quite stark and poignant, involves Dr. Benjamin Spock, who was a pediatrician and an author of probably the most influential child care book of the 20th century, Baby and Child Care. This book was published in 1946, and by the mid-70s it had sold millions of copies. It was easily the best-selling title by an American anywhere in the world, been translated into many, many languages. And as Dr. Spock himself mentioned, when the book would run out of print, he would get requests for more copies, not only from parents, who were the primary target market, but from schools of social work, medical schools, teacher training schools, obstetricians, pediatricians, even state health departments. This book was widely used as a resource in guiding decision-making about childcare. And the book itself contained predominantly the observations, experiences, and judgments of Dr. Spock as an individual pediatrician. Now, Dr. Spock was a very bright man. He was, by all accounts, an excellent and very caring pediatrician, and he was a very articulate communicator of his information and his experience. But ultimately, Baby and Child Care was the distilled experience of an individual, and as I've mentioned, there are a number of reasons why that kind of individual experience is unreliable in many cases compared to controlled scientific research. So one key example of this is the advice Dr. Spock provided for preventing sudden infant death syndrome. Sudden infant death syndrome is a terrifying entity in which apparently healthy infants die suddenly and without warning, often in their sleep. And this, of course, is a very frightening prospect to parents, and parents are always interested in ways to try to guard against this. Dr. Spock's advice, in order to prevent SIDS, was that babies should sleep on their stomachs. And his advice was based on his experiences and also on the perfectly plausible rationale that babies, as we know if we've had children ourselves, are very prone to vomiting. And if they are lying on their back and sleeping when they vomit, it seems more likely that they will aspirate or choke on this vomitus, and that could contribute to sudden infant death syndrome. So the key reason for this recommendation in terms of SIDS was that it would help to prevent this aspiration. The problem is that the controlled research evidence was developed early on in the 70s to suggest that this was the wrong advice and that babies, in fact, should sleep on their backs in order to help reduce the sudden infant death syndrome risk. From 1970, there was high-quality, systematic review-level evidence that sleeping on their backs was protective for babies from SIDS. However, this evidence was generally ignored, and Dr. Spock's evidence, which was much more psychologically persuasive and much more available to the general public, of course, was followed. A paper written in 2002 looking at the history of sudden infant death syndrome and sleeping practices suggested that if this systematic review level evidence had been heeded from the time it was available in the early 1970s, it could have prevented tens of thousands of infant deaths around the world, in predominantly the English-speaking world where Dr. Spock's advice was available and more widely heeded. And here's a little example of that. This is a graph showing the rate at which individuals put their babies to sleep on their belly, which is in the pink line, and the sudden infant death syndrome rate, the blue line. In 1991, in the UK, where this data was developed, there was a public information campaign called Back to Sleep, which endeavored to explain to parents that sleeping on their backs was safer for infants than sleeping on their bellies in terms of sudden infant death syndrome. And you can see from the pink line that this campaign was quite successful at getting parents to change their habits and to put their babies to sleep on their backs rather than on their bellies. The rate of prone sleeping, or sleeping on the belly, was still 70% in the early 1990s, despite, remember, the awareness from 1970 onward that this was a risk factor for sudden infant death syndrome. As the rate of prone sleeping declined following this public information campaign, the sudden infant death syndrome rate declined dramatically as well. Now, of course, simple correlation does not prove cause and effect, but I can tell you that there is much other evidence that, taken together with this, clearly shows that there's a causal relationship. So, following the sudden infant death syndrome recommendations based on good, sound, objective research turned out to be a much better bet than following the advice of even a very experienced, intelligent, well-trained, and well-meaning individual clinician. The notion that evidence-based medicine dismisses individual clinical experience entirely is, of course, a myth, partly because it's been recognized from the very beginnings of evidence-based medicine and human medicine that individual clinical experience is necessary and must be integrated with clinical research evidence. Dr. Sackett, who again was one of the founders of evidence-based medicine, in his seminal paper defining it and describing what it was and what it was not at that time, addressed this issue and specifically said that integrating clinical expertise was an important part of an evidence-based medicine approach, that there are things that individual clinical experience can do efficiently and effectively that need to be part of the healthcare process. One of these things is the efficient evaluation of what information is relevant and not relevant, which studies of expertise show that experts are very good at. Obviously, the human elements of compassion and the incorporation of patients' values and interests in the decision-making process are also elements of good evidence-based care that must be provided on the basis of the experience and skill of the individual clinician. And Dr. Sackett clearly and explicitly said, external clinical research evidence informs but does not replace individual clinical expertise. I want to quickly discuss a few other common misconceptions about evidence-based medicine. One is that it is impractical and not possible, even if it is desirable, because there's not enough time, there's not enough money, as we've already said, there's not enough evidence, or people simply don't care and aren't interested. I think that's a misconception. There's also the belief that evidence-based medicine can undermine the confidence of veterinarians and the confidence of clients in their veterinarians, particularly because of the explicitness about uncertainty. There is, among some, the perception that evidence-based medicine is cookbook medicine, that it ultimately tells clinicians what to do on the basis of objective algorithms written up by academics at a distance from the real-life, real-world clinical practice situation. And there is sort of a reverse to the concern that randomized clinical trials are overemphasized, which is the notion that if a randomized clinical trial has been conducted, if there is clinical evidence, that a practice is automatically an evidence-based sound practice. First, the question about whether evidence-based veterinary medicine is impractical. There is, as always, some truth to this. There's no question that there is time and training and expertise necessary, as well as additional evidence for evidence-based medicine to be effectively practiced in the veterinary domain. However, I will point out that just as the evidence base is improving, there are many other improvements in the tools and techniques and resources available to practice evidence-based veterinary medicine. This is just a brief listing of some of the many organizations that are trying to improve the quality of veterinary medicine in general, particularly through the use of evidence-based medicine. The Evidence-Based Veterinary Medicine Association is a group of interested clinicians and bioinformaticists and public health and nurses and librarians and many other individuals interested in supporting practitioners in practicing evidence-based veterinary medicine. Banfield's Applied Research and Knowledge, or BARC group, conducts research on the enormous database available to Banfield from its many practices and makes the information from this research available. It follows very clear and explicit evidence-based medicine guidelines, and that is a resource in private practice, and there are other private industry groups and organizations who are contributing to improving the ability of veterinarians to practice in an evidence-based way. The Center for Evidence-Based Veterinary Medicine at the University of Nottingham is an academic institution which is relatively new but has begun to publish important research looking at the way evidence-based veterinary medicine can be developed and employed in our profession. The Royal College of Veterinary Surgeons Knowledge Division is providing both research grants and regular conferences and meetings where people interested in evidence-based medicine can get together and discuss the needs of the veterinary profession and how evidence-based medicine can be adapted from the human model to veterinary medicine. The Association for Veterinary Informatics is a group of bioinformaticists looking at producing primarily information technology tools to facilitate developing and utilizing research evidence in supporting clinical practice. This is well developed in human medicine, and this is just the beginning of developing these tools for veterinarians. The Veterinary Medical Library groups are also very instrumental in helping to organize and disseminate research evidence and train veterinarians in its use. So evidence-based veterinary medicine is just beginning to grow in a dramatic and unprecedented way. And even though there are still barriers to implementing it, which we'll discuss in another lecture, it's getting better all the time. And there are a lot of individuals and organizations working to help bring evidence-based medicine to a more practical footing in the veterinary domain. In terms of the notion that evidence-based veterinary medicine undermines confidence, the confidence of veterinarians in their own decisions and the confidence of clients in the recommendations from their veterinarian, the main foundation for this is the fact that evidence-based medicine requires us to look at controlled scientific research evidence, to evaluate the quantity and quality of this evidence, and to explicitly acknowledge the limitations in the evidence that we use to support our decisions. If the only evidence available is anecdote or individual experience, it's important for us to acknowledge that this is deeply unreliable in many ways. And when there is published research evidence, and it has flaws or limitations, as all research evidence does, it's important in an evidence-based medicine approach for us to identify and acknowledge these limitations. This requires us to explicitly establish a level of confidence for our recommendations and our conclusions, and sometimes the level of confidence will be low, and we will be forced to say to our clients, I don't know, or there isn't enough evidence for us to make a clear, confident decision, and we must base our recommendations on lower quality evidence. While it is understandable that this can be threatening to veterinarians who may feel disturbed by not being able to express or to feel greater confidence in their conclusions, and it might potentially be disturbing to clients who would perhaps like confident answers and recommendations from their veterinarians, I think there are a couple of reasons why this is a misconception. First of all, knowledge is always better than ignorance, certainly for our patients. The more we know, even if it is about what we don't know, the less likely we are to make decisions on false premises and on unreliable knowledge. Confidently recommending therapies which do not deserve that confidence because the evidence is not there to support them is not in the best interests of our patients or our clients. And as I mentioned earlier, informed consent requires a full and accurate disclosure of the degree of uncertainty. Our clients might make different choices about our recommendations if they understood clearly the level of confidence that we could have in those recommendations. And it is our responsibility, under well-established principles of veterinary ethics, to make sure that our clients have any information that is useful to them in making decisions about the recommendations that we offer. And finally, there is some evidence that clients may actually prefer honesty about uncertainty to a false confidence. One research study looking at the perceptions of veterinarians and clients about the expressions of uncertainty that veterinarians might make in the clinic found that veterinarians significantly underestimated the desire of their clients to be told about uncertainties, and they significantly overestimated the degree to which their clients would lose confidence in them if they acknowledged these uncertainties and said that they were not sure. The study suggested that most clients do want to be told about uncertainties in the evidence and recommendations provided by their veterinarian, and that they respect the honesty that goes with that. So I think it is a little bit of a misconception to say that the explicit acknowledging of uncertainty, the quantification of uncertainty recommended by the evidence-based medicine approach, will undermine the confidence that our clients have in our recommendations. As for the notion that evidence-based medicine is cookbook medicine and undermines the autonomy of the clinician, this is untrue on many levels. There simply is no cookbook, and there never can be a cookbook. Medicine is complex. Individual circumstances associated with particular patients will always differ in relevant and significant ways that need to be understood and interpreted by the individual clinician. Evidence-based medicine specifically teaches independent appraisal of evidence and decision-making. It, in fact, frees clinicians from blind loyalty to the mentors or teachers or experts who so often provide us with interpretations of the scientific literature and what it means and what we should do. There is a tendency to rely on individuals, just as we relied in child rearing on Dr. Spock for so long, and to take their experience as worth perhaps more than it is. And this then makes the individual clinician somewhat dependent on the opinions of authority figures. Evidence-based medicine helps to free clinicians from that dependence and allows us to make independent decisions based on well-understood, well-developed mechanisms for evaluating the evidence, for identifying the information needs that we have in a particular situation and meeting those needs at that time. Finally, there is the somewhat perverse notion that because randomized clinical trials have an important role in evidence-based medicine, that anytime you have a clinical trial, you ultimately have evidence-based medicine. The fact is that not all clinical trials are equal. Some are better than others methodologically, and some have flaws which are in fact fatal and mean that those trials cannot be relied on, despite the fact that they've been conducted and published in the traditional scientific way. We are all aware of the fact that it's impossible to buy a shampoo or a makeup product or any kind of grooming aid without some sort of advertising suggesting that it has been clinically proven to make our hair shinier or make our wrinkles go away or make us more attractive. We know that simply saying something is clinically proven doesn't mean that there is real good quality science behind it. And that is as true in medicine as it is in grooming. Published studies are not automatically evidence-based medicine. Many studies that are published are in vitro or animal model studies or studies in non-target species, particularly studies done in humans and extrapolated to veterinary species. And these certainly can support decision-making, but they cannot be viewed as definitive answers to any particular clinical question. And studies that are of poor quality and not well controlled for sources of error that are at high risk of bias are often not useful and not particularly probative. This is partly why replication is an essential part of the scientific process. Any individual study is going to have flaws and limitations. The balance of the evidence when multiple studies, particularly replications of individual studies, are available, give us much more reliable evidence. So our conclusions should always be based on the preponderance or the balance of the evidence, and individual studies cannot be viewed as definitive in any situation. High confidence in our conclusions comes from high quality, consistent evidence at multiple. So what are the misconceptions about evidence-based medicine that I've reviewed? The first, of course, is that there simply is not enough evidence to matter and that it's not possible to practice evidence-based medicine. I think I've shown that while there is unquestionably less evidence, particularly high-quality controlled clinical trial evidence, than we would like, the amount of this evidence, the quality of this evidence is growing, and evidence-based medicine has a role not only in evaluating the evidence that exists, but in producing better quality evidence. Evidence-based veterinary medicine is not paralyzed without good quality, large numbers of randomized controlled trials. Evidence-based medicine does certainly have a special place for the controlled clinical trial because it is a very effective tool for identifying reliable knowledge. However, there are many other kinds of evidence that can and should be incorporated in making decisions about clinical questions. And evidence-based medicine provides us with an excellent way to establish a level of confidence in our conclusions and recommendations, regardless of the existence of randomized clinical trial evidence. Evidence-based veterinary medicine does not ignore the value or need for clinical experience. Individual clinicians have an indispensable role to play in healthcare and always will. Evidence-based medicine is about supporting individual clinical decision-making by integrating it with controlled research evidence. There's also no question that there are some pragmatic barriers to the practice of evidence-based medicine, limitations in time and money, and sometimes in the motivation or interest of veterinarians to develop their skills in practicing evidence-based medicine. However, there are many individuals and organizations in veterinary medicine actively and enthusiastically working to make evidence-based medicine a more practical tool and to improve the quality of care that we provide using the evidence-based medicine approach. So there's much that can be done today in terms of evidence-based veterinary practice, and there is certainly great hope for the future. The notion that evidence-based medicine undermines the confidence of veterinarians and clients, I think, is misplaced. I think an acknowledgement of the degree of uncertainty involved in any particular clinical decision improves the quality of care that we provide, and I think clients want and expect us to be honest with them about such uncertainties and about the quality and limitations of the evidence we're using to establish the recommendations that we give them. And finally, the notion that, hey, if there's a controlled clinical trial, then whatever you're studying must be an evidence-based therapy is clearly not true. Evidence-based medicine requires us to evaluate the limitations of all forms of evidence, including randomized controlled clinical trials. And often, it is not possible to make definitive decisions on the basis of the existing evidence. In particular, it's important to understand that no single trial can ever be definitive. Replication is an essential part of good scientific practice. Finally, I think it's important that we consider what are the alternatives to an evidence-based approach to practice. We've already discussed a little bit personal experience and why the experiences of individual clinicians, while invaluable and indispensable in clinical practice, are subject to a number of sources of error and are not the most reliable way to develop knowledge about the effectiveness of particular interventions, the causes of disease, things that scientific research does a better job at. And the following of tradition of what other veterinarians who've come before us do or have done is in many ways simply reliance on individual experience accumulated over time, which unfortunately is not that much more reliable than the experience of single individuals. We talked a little also about the reliance on expert opinion or the authority of opinion leaders. And unfortunately, even smart and well-educated and experienced clinicians, such as Dr. Spock, are subject to making mistakes, like all human beings are. And the slavish following of the guidance of experts is a dangerous approach to medicine and can lead to the perpetuation of errors for long periods of time. Evidence-based medicine helps to free the individual clinician to some extent from this reliance on authority or expert opinion by teaching individual clinicians how to evaluate, how to identify their information needs and find evidence and evaluate evidence for themselves. And that kind of independence or autonomy helps to guard against the perpetuation of errors based on the opinion or experience of individuals. Similarly, reasoning from basic principles or theory is a common way to make decisions in the absence of reference to external research evidence. If we have a certain understanding of basic physiology or of a particular pathophysiology of a disease, we are tempted to use that understanding to guide us in which interventions we employ. However, there's extensive evidence in medical history that that's not a reliable practice for many reasons. Oftentimes, there is some small fact that we have wrong or that we don't know, and that leads our perfectly sound chain of reasoning from basic principles to clinical practice to be flawed, and the clinical interventions we developed on the basis of that sort of theoretical reasoning turn out not to work. Clinical trials are important for many reasons, but precisely in this case because they help to control for that source of error. So while there's no question that there are many ways in which evidence-based medicine is not a perfect system, and there are many legitimate objections to it, it's important that at least we understand what evidence-based veterinary medicine is and what it is not. And many of the most common and widespread objections to using this approach turn out to be based on myths and misconceptions. Hopefully this lecture has helped to clear the air a little bit and make a little more clear what evidence-based medicine is and what it is not, and why some of the myths and misconceptions about it are not a useful basis for debating the merits of evidence-based veterinary medicine.